Today, we're going to have an informal panel presentation on uh, urban health, urban health infrastructure, and the factors that lead to change and development in the urban health infrastructure. And I just say that a public health professional might do an analysis of what the needs are in various parts of, say it's urban, various parts of the city they work in, and uh, and then or come up with the financial resources, presumably often through taxes. I suppose it could be done in other ways if you had a public health model, and then distribute those resources in a manner such that the community's health needs are served. So that would be a public health model of how to organize services. But the goal of this panel today is to discuss how things work here in three cities in the United States, which I think probably overall do represent uh, the the way things could happen really in any city in the United States. I don't think they're that unique. So my name's Marvin Malik. I'm the one of the preceptors for the Northern New England Health Public Health Policy Internship Program. And I'm going to start today with our first guest, Walter Tsou. And I just want to say I didn't I couldn't find your bio in my list of bios. I did find it for the other two guests today, but instead of you suddenly emailing it to me and me trying to dig it out, I think it's maybe more of more instructive for the interns to actually listen to some of the events that happened to you in your career and how you got to be at a high position in the city health department in Philadelphia fairly early in your career, and later on had done enough to become president of the American Public Health Association. So I'm wondering, Walter, if you could tell us about that phase, where you went to medical school and what your goals were when you left medical school, or even when you entered it, and how that changed over time, and how you sort of leveraged available resources to advance the public health as best you could. Is that a fair question, Walter?
Sure, that's a fair question. That could be like 5 minutes or an hour.
Let's look for 10 minutes.
Okay. Well, I grew up in the suburbs of Philadelphia. My father was a PhD in chemistry, and I was thinking of following his footsteps and be a chemist. And he said, "Well, listen, if you want to make more money and work less, go to medical school." Because he spent his entire life trying to get research grants, which was very hard to do. So I listened to his advice and decided I wanted to go be pre-med. And of course, like everyone else, I wanted to try to help people. And the long and short of it is that I did study at Penn as a pre-med, and then I went to Penn Medical School. And I think one of the striking things for me that I always tell people is that I spent 4 years at Penn. This is many years ago, and the word public health, amusingly enough, never came up in the curriculum. I mean, people would talk about public health, sort of euphemisms, but the idea of even thinking about what public health really was about, having faculty members who were trained in public health, really never came up. And so, I'd sort of follow like most of us as lemmings, and we, most people decided to go into some type of specialty. I decided to do internal medicine, and I did my 3 years residency at Presbyterian Hospital in West Philadelphia. And every day, of course, I'd see people who came in with seizures from alcoholism, heart attacks from people who had high blood pressure and diabetes, on and on and on. And it was pretty obvious that there were things that we could have prevented. People came in just sort of in advanced stages, and it was sort of hard to take care of them after that. And I got like, sort of intrigued by the fact that maybe we could prevent some of these illnesses at an earlier stage. Um, I decided though that I would go into private practice. That's what a good internist does. And I was waiting for an attending to put his arm around my shoulder and say, you look like a smart guy, Walter. Why don't you join my practice? And, you can take all my call and so on. And then eventually maybe you'll be a partner in my practice. But to my chagrin, nobody put their arm around my shoulder. And but one person said to me, there's a public health clinic in Philadelphia, in West Philadelphia, and they're always looking for doctors. Why don't you just work there for a year? And I said, well, I guess that's true. That's my best alternative. So I would do that for a year and then wait for the arm over my shoulder to come. And what I found was working in a public health clinic was very different than working in the hospital ER. I mean, we had patients who were really desperately poor every day who relied on me as a physician. And every day I'd literally every day I'd have somebody say to me, I'm really glad this clinic exists. I'm really glad that you're my doctor, because were it not for the fact that this clinic existed, I don't know how I'd pay for a doctor visit. I don't know how I would afford my medicines. Our health center actually provided medicines for the patients. It was run by the city of Philadelphia. So that was sort of encouraging. In fact, I got to know my patients, not like the ER where sometimes they're frequent flyers and they show up in the ER and you kind of know who they are. But here, we really had scheduled patients, and they'd come in, and I did what I thought would be a 1-year stint, turned out to be a 9-year stint. I ended up working in these city health centers, at different health centers, for like 9 years. And I realized that this area that I knew nothing about, working for the Philadelphia Public Health Department, was actually my new career. I actually thought it would be kind of interesting to work in public health. So I decided, what do people with public health do? They get a public health degree. So I applied to Hopkins and I got accepted, and I went to get a master's in public health. And the great thing about having worked in the health department for in the clinic for so many years, was that actually the public health curriculum made sense to me. They would talk about issues around access to care or problems with epidemiology and biostatistics. And to my great amazement, I actually had a context upon which I could understand these theoretically esoteric topics. And it was very real to me. And I decided that actually public health, after my year at Hopkins, I would do that. But I didn't want to go back to Philadelphia and work in a public health clinic again. I mean, why? It's kind of a waste of my time to get a public health degree. I told them that I'll come back, but I want to work in the main office, and I want to take care of some of the administrative policies that I thought were very clinically, obtuse, I guess, in a way, because they weren't really reflective of what everyday clinicians really needed to do. And so they reluctantly agreed, because I told them that was the only condition I'd come back, and they liked me, I think. So I worked in the central office, and I worked on starting screening mammography programs. I can go on a long discussion, but at the time, the city of Philadelphia was bankrupt. It had just gone through something called MOVE, which some of you probably don't know anything about, but actually they bombed this row house in Philadelphia to try to get people to evacuate, believe it or not. And they caused a fire that burned down an entire city block. The city went bankrupt for doing that. And we had no money. And we also knew that women were getting we're not getting mammograms, even though it was sort of recommended that they do it. In retrospect, of course, it's so obvious. But at that time, the only way you could get a mammogram for a woman was to say, I felt a lump. You had to lie and say, I felt a lump. And so you could get a diagnostic mammogram that they could pay for, but they wouldn't pay for a screening mammogram. So anyway, I worked on trying to use my public health ideas, skills, and think about how we might do a citywide mammography program. And that actually turned out to be a wonderful opportunity to really apply some of the stuff I learned in public health school on a larger population basis to try to get low-income women into screening mammography. And I worked with the American Cancer Society, which is why I always give money to them. And they gave me a small amount of money to start a screening mammography program. And lo and behold, we found several breast cancers through the program. As one of the docs said to me, just one of those would have probably paid for the entire program, the fact that we caught it early. And then after that, actually, a friend of mine told me that they had a county outside of Philadelphia called Montgomery County. It's, if you're not from Philadelphia, you would know it better. At like Valley Forge is out there, and there's King of Prussia, some of these other places. Anyway, it was the largest county in America by population without a health department, believe it or not. It had 678,000 people at the time, which was bigger than the city of Baltimore. And it actually had no health department. And they wanted to start a health department. And my friend said, why don't you and I help start a health department there? And I said, well, I don't know. I'm having fun in Philly, but he said, you'll please. He said, I said, are there any poor people out there? He said, yes, of course there are poor people here. So I said, okay, I'll go out there. So I helped start a health department from scratch in Montgomery County. It was really quite an amazing experience to try to start something like a public health department. And we used a lot of my ideas about what I learned in public health school, and some of just working in Philadelphia to think about how we would reorganize a public health department. Well, I did that for another 8 years or so, and then the mayor changed in Philadelphia, and a new mayor came in, and they were advertising for the health commissioner job, and I thought, why don't I go back and apply? And the fact that I had worked in Philadelphia for many years and that I had worked in a neighboring county was very attractive to them, so they picked me to be the health commissioner. So I did that for a while, but the mayor's wife wanted to take all my money from there was something called the tobacco settlement, where some of you may know that the tobacco companies gave each of the major cities a lot of money to do smoking cessation. And I wanted to do smoking cessation, but she wanted the money for her after school programs. And of course, the mayor's wife wins. But I told her that that was not a good idea. But anyway, the long and short of it is that I eventually decided this was not the place for me because the mayor's was not prioritizing public health. And so I ended up leaving. And then I was at the time on the board of the American Public Health Association, and they asked if I wanted to run for president. And I said, why not? So I ran for president of APH, the American Public Health Association. And so I got elected, and I ended up doing that for a year or so. And then I decided, I had a choice at that point about whether I stay in Philadelphia and do another, but I had basically done every public health job in Philadelphia. There was nothing really more to do. Or I had to leave the city and move to someplace else and do public health. And I decided I didn't want to leave Philly because my family was here and so on, kids in school. So I decided I would just retire. So maybe I would just pursue public health, work on things like PNHP and single payer stuff, causes that I believed in, and help promote public health. And that's basically what I've been doing the last, decade or so, is to work on public health stuff and in the city. One of the things that is attractive, actually, is the fact that it's very hard to get the health commissioner to actually make a public appearance or make a pronouncement about some public health topic, because they have to get it screened and the mayor has to agree and so on. It's very cumbersome. But for me, since I'm a free agent and since I was a former health commissioner, they would call on me all the time. So I was asked a lot to go to press conferences and to talk about public health stuff. And I like to do that. It was fun. And I sort of parlayed my public health um, background to the betterment, I think, of trying to promote public health in the city and other areas.
Yeah, Walter, let me stop you just for a second. So you you managed to become president of APHA, and that thereafter you have a little bit more power because you've had this honor of being elected president of an organization with, 15 plus thousand members. And the two ways that can be beneficial in terms of you accomplishing uh think advocate say for you to be able to advocate for policies you believe in. One is that it's a great title, so thereafter more the press may seek you out and ask for your opinion on something. And as you said, you're then when you're no longer employed by a government organization or even a private one, because I can tell you it's difficult to speak out when you're in a private organization too. More on that in the internship later, not today. But you're so it was a nice credential to have, and it, in a sense, by itself amplified your voice. And then the other way is that you could try to get APHA to change. APHA is a progressive organization, but I don't think it does a ton for advocacy, say for universal health care. It doesn't really spend that much time on that. So you could try to change the organization itself. Would you agree with that assessment that those are two advantages?
Those are two advantages. Uh, I should point out that APHA 2 years ago gave its highest award to Ali Fine, who some of you know is a past president of PNHP. And Ali gave his, award address basically devoted to why APHA should be fighting for single payer. And I think people, I don't want to say that APHA doesn't support single payer. It does support single payer, but it does, like a lot of mainstream health organizations do. They sort of live by the times that we're in, and it's a member organization, and there are a lot of members who are employed by the for-profit system that we live in, and so they become they become a little bit more hesitant about being too critical of the current system. Those of us who are not, who have affiliation with APHA are much more likely to speak out on why we should have a single payer universal healthcare system. And I've talked to Georges Benjamin, who's the executive director of APHA, many times. He knows that he supports single payer in his heart, but he also, runs the fine line of trying to make sure that none of his members flee because we take a position that is not consistent with the current Affordable Care Act that we live in today. Which is why it's very important for all of you to be part or skilled in this area, because the ACA has many flaws in it, and to express a different and more progressive vision about why the healthcare system would help cure many of those flaws and give us a better vision about healthcare is one of the reasons why I think Marvin has helped put together this training program. So I appreciate what you're doing.
Walter, I'm wondering if we could now talk about a little bit, at least, about the history of Philadelphia's healthcare infrastructure and what factors have guided what hospital opens a service, what hospital shuts down, and the factors that lead to that. And I have to say that Philadelphia, I said earlier that it's representative in most ways, in many ways it is, of what's going on elsewhere. But you have had two pretty spectacular hospital closures of safety net type hospitals. I guess one, I think Philadelphia General was a public hospital, safety net hospital. And I think it closed in the late 70s, maybe, some plus or minus a few years. And much more recently, there was another hospital closure. So if you don't mind giving a context for that and why it mattered to the public health and access to care for the citizens of Philadelphia, and in particular, what communities those closures may have harmed and
Well,
why these decisions
how
are
much
made.
time do I have? Because I have a little slideshow I could show you, but I don't want to
Yeah,
step on
put it
people's.
up and we'll try to get this part over with by maybe, I don't know, 15 minutes, say.
Okay,
Give it
maybe
your
I'll
best.
breeze through it. But let's say that at one time there was a Philadelphia General Hospital, which was at the time considered neck and neck with Mass General Hospital as the place where you wanted to get trained because there were so many patients that would come in there. The teaching hospitals were first rate that came in there, and it was very prestigious to to have a PGH residency. And then, but it was owned by the city of Philadelphia, who knew nothing about healthcare and only saw it as a loss leader. And unfortunately, it underfunded the PGH program, and it basically collapsed, as you pointed out, sometime around 1976, 77. And it was one of the great tragedies that we are the I think it's still true, the largest public city without a public hospital. And the distinction is now that every hospital in Philadelphia is asked to take care of the poor and indigent. And of course, with our very crazy market-based system we have, everyone has their own ideas about who should bear the responsibility for these very expensive cases. So with that, if I could share my screen, can I do that?
Go right ahead. What populations did Philadelphia General serve? Was it disproportionately poor or minority populations?
It was disproportionately poor and minority patients that. Can you guys see that at all or not? You can, okay. Yeah, it served everybody. It was the place where people could go if you didn't have health insurance or didn't want to go to Temple or Penn or Jefferson for your medical care. You could go to PGH. It was also, ironically, the place where they would house all the homeless. It was this enormous building. So the homeless, you basically were out of the streets during the winter time because you were at PGH and they would feed them. And I was always told that the best ice cream in Philadelphia was at PGH Hospital. Anyway, this is sort of a map of Philadelphia, and I don't know if you know much about Philly, but it has these academic medical centers. There's Temple, Penn, and Jefferson, the big three. Hahnemann, which was affiliated with Drexel Medical School, was right in the middle of all this. It's sort of like at the cross section of these two major roads that define Philadelphia. But the owners of Hahnemann, which was a nonprofit, was bought out by a for-profit hospital system called Tenet. And then Tenet held on to it for, I don't know, 5-10 years. And then they sold it to American Academic Health System, which was funded by Paladin Healthcare Capital and was sold in 2018 to Apollo Capital Management and Harrison Street Real Estate Capital. Now, yeah, Mike, what does a real estate capital firm want to do with Hahnemann?
Walter, these all three of these were private equity investor owned, right?
Yeah, they were
Yeah.
all these private equity investments. So a year later, in 2019, Hahnemann declares bankruptcy, and they argued in bankruptcy court that the real estate holdings should be excluded from the bankruptcy proceedings. And, we nefariously understand now that the real intention, I think, was they never really wanted to run a hospital. They really were interested in the real estate holdings. And the reason why, of course, is that Hahnemann sits in this incredibly low location. This is City Hall. It's within eye shot of Hahnemann Hospital, which I show you here. And this is the Pennsylvania Convention Center, which is, a fantastic place to have maybe a hotel or condo. And you could send people to this great location. Well, when they closed Hahnemann, I took these pictures on one of these protest days. They had this big demonstration in front of Hahnemann Hospital. The doctors and nurses came out and said, this is outrageous, simply closing the hospital. And I'll just show you some pictures. People saying patients now profits, keep Hahnemann open, and of course, not surprisingly, the Medicare for all people were out in force. You can see here's a picture of Hahnemann, and right behind this woman, Lady Liberty, is City Hall. And here's speeches in front of City Hall saying, save our hospital, save our nurses, save our patients, Medicare for all at Hahnemann. But a year later, despite all that, they closed Hahnemann. And you probably can't see it, but on the wall of Hahnemann Hospital at the closure, the staff put on the windows things like medicine was here, or radiology was on this floor, or food services, or, this is where they did pharmacy and so on. The point here is that they wanted people in Philadelphia to know that something really important healthcare-wise was happening in our hospital, and they put these banners up on their windows to show what it meant to close this hospital. And part of the issue around hospital reimbursement comes down to the kind of case mix. If in a city which does not have a public hospital anymore, you decide where you're going to dump, people who have terrible insurance, and a lot of them dump them in Hahnemann. And so there were a lot of Medicare or Medicaid patients who were sent there, a lot of uninsured. And the big systems like Jefferson and Penn, they're big, so they can negotiate with the Blue Cross Blue Shields and the other insurance companies, and they negotiated better rates for their services. Hahnemann, being smaller and not with the financial cloud of Penn or Jefferson, could not negotiate better rates. And in a market-based system, of course, that was a losing proposition, and they just simply didn't have the reimbursements that they needed to keep their goods open. Its impact on Drexel Medical School, well, there was a medical school called Hahnemann, founded in 1848. So we're talking about a building that was created here over 150 years ago. And it merged in 1996 with Medical College of Pennsylvania to form Drexel Medical School. Well, Medical College of Pennsylvania was founded really as Women's Medical College in 1850. It was a women's medical college because women could not get into medical school. And so the history of Drexel really is formed around Hahnemann and Women's Medical College, a sanctuary, if you will, for many, many women who could never have gotten into medical school. And all that history basically was lost with when it created Drexel Medical School. The major academic medical center for Drexel was Hahnemann. And when Hahnemann closed, all these residents, 560 residents, you imagine you were in the in your training program at Hahnemann, and suddenly you find out they go bankrupt and they're closed. And you discover that you have what they call claims-made insurance, which means that they will cover you for the time that you were working as a resident. But if something bad happened to you, a mistake maybe that happened, a malpractice case came up, after you left, you do not have any protection at all. It was only for the duration of the time that you worked at Hahnemann. That is to say, it was the cheapest malpractice insurance they could buy for the residents. Well, the residents were upset, needless to say. And they wanted occurrence. They called occurrence insurance, malpractice insurance. And that would actually cover them should they actually get a lawsuit after they leave. And that turned out to be a major debacle as to who's going to come up with the money to pay for the occurrence insurance. The impact on neighboring hospitals was really also profound. Jefferson, which is the closest hospital to Hahnemann, went from 200 to 300 patients every day. Every day there would be 35 patients waiting in the ER, hoping that a bed would open. This is told to me by Ted Christopher, who was a friend of mine, who was the director of the Jefferson Emergency Room. In the middle of the pandemic, they wanted to open up Hahnemann again so that they could house on an emergency basis people who needed to be hospitalized for COVID. Remember that. And Joel Friedman, the guy who was the head of the real estate group that owned Hahnemann, wanted $1 million a month to open Hahnemann up, which was, the city was outraged. They said, forget it. You know, what is your civic responsibility? Yeah, no. Well, what I'm telling you is sort of this private equity formula, which is that in many hospitals that are on the margin right now, they bail them out because they sit on prime real estate. I mean, Hahnemann sits on a real estate location, as I showed you in the map. That's the crossroads of two major roads in the city of Philadelphia. And it's a few blocks from the best location in terms of convention center and the city hall. And you have, if you're a private equity firm, you could decide that you can let the hospital close and then you take over the real estate and then use it for development. Or you can keep the hospital open and then you would sell the real estate to another developer and then you would charge the hospital rent for the very property they used to live on, because now the private equity firm has sold the real estate for a lot of money. So the goal really is not for patient care, it's really for profit. Another hospital, just quickly I'll show you, is Crozier Hospital in Chester, Pennsylvania. It was owned by a for-profit group called Prospect Medical Holdings. They sold the real estate underneath Chester Health System to a group called Medical Properties Trust. And they started charging Crozier Hospital $35 million for rent, which basically forced the hospital to go bankrupt. And this kind of scheme is really pernicious because these guys are not interested in patient care. They're only interested in the real estate value of these hospitals, which is a public trust, which people give the best real estate in their city to hospitals because they want easy access to their citizens. And unfortunately, this is replicated throughout every city in America. I know very little about Steward Healthcare, but I read some things about this, and it's closer to some of you people in New England. It's a real estate is also owned by the same company, Medical Properties Trust. They started charging rent again, and Steward just recently declared bankruptcy. It's unable to, its plans sometime this month to start selling its Massachusetts-based medical center. And as WBUR, the NPR affiliate, said in their headline just few days ago, unnerved by bankruptcies, the doctors and patients are leaving Steward hospitals. So we're sort of seeing this trend happening where healthcare is seen purely as a for-profit real estate venture and not so much for the benefit of patients. Which raises, of course, the ultimate question, is healthcare a public good? or is it a market? And I'll stop it.
All right, Walter, that was great presentation. Any questions from the interns at this point? All right, well, if not, feel free to ask. But we'll, at this point, maybe let's turn to Susan Rogers. And let me. Yeah, here we go. So Susan is from Chicago, and she's, am I correct, Susan, in saying that you've spent pretty much your entire life and career there in Chicago? Is that
Yes,
correct?
yes, I
Okay.
have.
So I'm looking for your bio and I haven't found it. So why don't we just do what we did with Walter, and if you could tell us about your experiences in Chicago, what led you to want to go to medical school, and then where you were trained, and what went into the thinking that you did about how to direct your career, what you were going to choose to do with the training that you got in medical school and residency. So tell us about that.
Sure. Thank you for inviting me to talk again to these upcoming positions and share my story of how I got to be where I am today. I grew up in Chicago, and when I was in, I guess, 7th or 8th grade, Martin Luther King came to Chicago to march against the segregated housing that was rampant in Chicago. Chicago was a very segregated city. And I grew up in an area called Hyde Park. I don't know if any of you are familiar with Chicago, but it was a very well integrated neighborhood. And my friends were multiple different races, different economic groups. And to me, that was normal. That was how everyone lived. And so we went to this march downtown where Dr. King had come to march against the fact that education was so segregated in Chicago, and it was around community boundaries. You know, the Black community had their school, the white community had their school. And we went down there, and I was just amazed. I was just amazed at what I saw, what I heard. And as time went on, I began to realize that how I was growing up was not the usual way that most Black children grew up, with an integrated environment. And my mother was promoting for better schools at the time. I was, the high school that I should have gone to, the public school, was overcrowded and they didn't know what to do. But it made me realize that things were inequitable. This was also at the time that the Black Panther Party was growing and becoming more visible and powerful in Chicago. And I became an Angela Davis wannabe. I had a huge fro. That was the way it was back then. And it became important to me, the whole issue of civil rights, of equity and education and all of this. And that sort of has driven my journey since then. And I look at what I've done, and it's all been because of those roots. And it made me realize how where you live really determines so much of where you can go and what you can do. One of the things that I didn't know that I wanted to go into medicine at the time, but when I was a freshman in high school, I took biology, and I just fell in love with it. And I didn't know what I was going to do with it, but that was my interest. I didn't, like I say, I didn't know what I was going to do. And I didn't even know when I went to college. And even my college experiences shaped my vision and shaped what my goals in life were. I went to a small white college in Colorado. I was very excited about it because you took one class at a time. And at the time I was growing up, the world was small. And I felt that if I didn't go to Colorado now, I'll never go to Colorado. You know, it was so far away or whatever. And I went there, and it was one of the wealthiest, whitest schools I've ever seen. And I realized that the other students there, their idea of a summer job was taking care of their neighbor's horse, which was a totally different experience than mine growing up in Chicago. And I stayed there 2 years, and then I left, and then I went to HBCU. And I was only there for a year because my mother became ill, and I decided to stay in the city that for my last year. And I still didn't know what I was going to do with this biology degree. But then I went to a commuter school in Chicago, got involved with a group of students who were going into who were trying to get into medical school. And so I got involved with that group, applied to medical school, and got into the University of Illinois. And so that was how I got there. And that was also when I decided that I am going to train at Cook County. I never set foot in Cook County, but I knew that that was where I wanted to go because that was my mission for becoming a physician. I was going to take care of Black people. That was the whole reason to go. I wasn't thinking about money. I didn't even think about the specialty I wanted to do, but that was where I wanted to go. And actually, that was where I met Dr. Malik.
Yeah, you were ahead of me and one of the people who trained me, so thank you for that.
You're
But
very
maybe at this point, before you go on with your own, what you've done is tell us about Cook County Hospital and its history and legacy, and about the county hospital system there. The
yeah.
public hospital, right?
Yes, it was a public hospital that took everybody who showed up at the door. In fact, we still do that now, although it's a little bit different with privatized Medicaid and Medicare and networks and all. But it was an amazing place. And I found that people were so appreciative for the care they got. But I also saw such healthcare inequities and really poor medical care delivered to a lot of the patients who were there because they were poor and Black. And there was no sense of wanting to learn about what their life was, why they got to be as sick as they were before they came in, or whatever, things that I just thought you would want to know. And so I trained there. And actually, when I was a senior in medical school, and a requirement was you had to do a senior internship in what specialty you wanted to go into. So I did a summer internship there, senior elective. And that was the first time ever that I worked with a Black physician. And that was a resident. It wasn't even an attending, but it was the first Black physician I'd ever worked with in all of my medical student days. And that was where I decided I wanted to go. And so that's where I went. And I found it to be just an incredible experience. I became chief resident after I finished, and that was a phenomenal experience. And my goal was to be a clinician. I didn't care about research. I was just going to take care of people. And so I went and worked for an HMO thinking that was the way to deal with the financial inequities that people face. And then that didn't work out. And so I came back. I went to the VA. I went to a FQHC, was a medical director there for a while. And then I came back to Cook County. And that was when that's where I finished my health career. And I found it phenomenal because I found that patients were so appreciative. And it was also an opportunity for me to expose some of the behaviors that were so inappropriate by physicians who were not of color, who did not understand the culture of the patients that they were taking care of, who did not bother to talk to patients. It was a very eye-opening experience, my years at county. And even though I left, I did return. I came back to Cook County. I was a primary care physician in one of the clinics for many years, and then I became a hospitalist and came back to the hospital and practiced there. And I became the clerkship director for the M3 students who were at Rush Medical School that was across the street. And so I finished my career then. I did retire a few years ago. But I just so enjoyed my time at county, and it just helped me grow, not just as a person, but as a physician too. And I became a better physician because of my experience there. And that was also where I met physicians who were engaged in fighting for single payer healthcare. Because that was actually the way we practiced at Cook County. I never asked about insurance. I never asked, can you afford this medicine? It was all free. It was all covered while we were there. So I was only a physician. I was not a finance counselor. I was not any of that other stuff involved in trying to get access to care for the patients that I saw. And so I've just found that it was just an incredible experience. And one of the things I would like to say to you students is that I know finances are much different from when I went to school. I'm embarrassed to say how little I had to pay going to a state school back in those days because there was a marked difference. Now they're all multi-$1,000, tuitions every year. But it was just an incredible experience, and I felt that I learned and I could teach there, and I enjoyed it so much, and it made me just a better person all in all. And as a PCP, one of the things I did learn was as a PCP, I took care of patients. As a hospitalist, I took care of problems. They're two, even though you're studying the same diseases in a way, but in different venues. And so just decide what you like doing. And I know you have incredible debt you likely have to pay back, but making a lot of money isn't going to make you happy. And doing what you want to do, you still won't be broke. You may not be able to buy a Mercedes, but you will still have a car. And I think that it's important that you do what you want to do, what allows you to sleep well at night, what allows you to be the example to your children that you want to be, and to be the type of doctor that you want to be. And I have no regrets out of anything that I have done as a physician. I'm not saying I didn't make mistakes. I regret those, but I look back at my journey, and the only thing I wish I hadn't done was retire as early as I did. I wish I had continued a little longer, but that's neither here nor there. But then I got more involved with PNHP, so I didn't waste my time doing nothing. So that's my story of how I got to where I am.
Thank you. I think that's of interest. Can I ask you just on a slightly sort of unrelated topic? Last week we were talking about mainstream strategies for cost control. And basically the whole movement to have value-based care is going along on the assumption that providers really aren't careful. They order too many tests, and if they're monitored either by intrusive insurance companies or are in some sort of financial disincentive system like the Center for Medicaid, the Medicare bureaucracy is creating, that'll rein in all that profligate test ordering. On the other hand, the Republican Party and more conservatives say, well, patients need to have copays or they'll just want too many tests. Now, you said earlier, and this just 10 minutes ago, that the patients didn't face copays and deductibles, and probably you would say that you were ordering tests when you thought they were necessary and you didn't really think about costs. Do you feel like, was the complement of tests those patients received, did you ever felt like the patients should have copays because they want too many tests? I mean, how do you feel about these strategies to make patients pay more or to try to get providers into these networks and all that stuff to control costs. When you look back on your own work at County Hospital, without those constraints and without patient co-pays and that, did it, were, were you expensive? Like, were your patients expensive for the,
Yeah, most of the patients I saw were sick. And they came in with late stage diseases or uncontrolled diabetes, uncontrolled hypertension, and they already may have had complications. But I think that one of the problems with the county system was that I don't want to say that we were all self-taught, but we didn't have the hierarchy of teaching that there is now. When I was attending on the service, I was the one who said, "Why are you ordering that test? You don't really need that." That wasn't really said to me. But I ordered tests more because I wanted to know what was going on. It wasn't because we do these all the time. There was still some guidance in what we did. It was difficult to get specialists because of the volume. You couldn't always get somebody to see a patient for another problem. Whereas now, if your knee hurts, you go see an orthopod. You don't think about, is that something that a family practice or general internist can take care of? Patients even want specialty care for whatever the complaint is. That's part of the difference here that's happening nowadays. But I never thought that we really ordered too much. I think we were often looking for solutions, and unfortunately, there wasn't a lot of guidance, and there wasn't. It is totally, medical teaching is very different from how we learned at County. But I think that our mission, though, was to find out what was wrong and treat it versus making money, which is, I think, a big impetus now in how a lot of physicians practice.
Susan, I'm going to go back to what you just said. I asked you about the mainstream cost control strategies, and you almost immediately said, we treated really sick people with late stage disease, and they're very poor. They didn't have access to primary care or to other services throughout their lives. And so there they are with late stage disease. My memory of working at County is that every test was positive. We ordered a test. It always showed something, often really bad stuff. We saw late stage disease. And so going back to your words, it sounded like rather than all these fancy financial strategies, making the patients pay or whatever, you're bringing up social determinants of health that make their care really expensive. If we ordered expensive tests, they would be positive. So I think the social determinants in the case of especially poor communities, they're going to generate high costs, high healthcare needs. Would you
Yes.
agree with that statement?
I would agree with that. I mean, a lot of patients we saw had multiple medical needs when they presented because they couldn't access care before. And then the other thing too is there were a lot of patients who were depressed and lonely that we saw, who wanted something addressed, really, which was not necessarily a medical problem, but a mental health problem. And it was difficult for us to get those. But yes, I don't think we wasted time ordering things that were unnecessary because we were just so busy and so many of our patients were so sick that what we did was needed. And we had probably more difficulty getting people to see patients because the volume just overwhelmed the system versus we were overwhelming the system with unnecessary tests.
So Susan, you mentioned earlier that Chicago's segregated by race, and it has a reputation for being one of the more racially segregated cities in the country. With the north side where the white people live and the south and west side where Latino and especially Black people reside. So And just to note, if you add up the area and the population in the south and west side, it's much larger than the north side. So a lot of people. I would like you to talk a little bit about access to care and hospital care and how that goes, whether those communities, many poor communities, minority communities on the south and west side of Chicago, how they get hospital care. And I think obstetrics has been an especially big issue, but if you could talk a little bit about that story and how secondary, basically hospital care goes on the south side.
Yeah, it's very fragmented because on the south side of Chicago, where more people go without insurance, have difficulty with copays and other associated bills associated with their health care. And there are medical deserts now. There have been multiple hospital closures in Chicago, along with in rural areas, because lack of physicians and because we have a medical system that is based on money. When you have patients who cannot pay, or you are funded only by mostly Medicaid or Medicare, you often do not have the funds to meet the needs of the patients you see. So our patients often end up not getting the adequate care. And what happens too is that I'm not far from the University of Chicago, and the University of Chicago is known for not treating patients or diverting patients to other institutions because of the type of insurance they have or the lack of any insurance at all. And I know Cook County used to get those transfers all the time, and they would be sent with a note, not even a medical record, but with a note saying this is what this patient needs, but without the information for you to act on that decision appropriately. So the hospitals within the city in poor communities either are working on a very thin budget, just an inch away from bankruptcy. Those hospitals are not as not even luxurious. They often don't have minimal services that they offer, and they often are not welcoming to patients who do not have money. And that's clear. That's been shown that patients who have Medicaid do not feel welcome. People of color do not feel welcome to institutions where most of those patients are privately insured, who can afford their copays, who can afford their deductibles, and who can afford their medications. It makes it easier for a physician to see patients like that who can do what you want them to do to get better. Even at Rush, which is right across the street from Cook County Hospital, is got billions of dollars in assets that's located across the street from a hospital that often doesn't have all the medications that their patients need. So there's such an inequity, but it's all based on money. And because it's based on money, it is therefore based on color of patients. And that is diverse and throughout our healthcare system everywhere. And especially if you look in the southern part of the country, it's horrendous. What is there? The inequities based totally on money, and the fact that many southern states do not want to fund those patients at all. They didn't take Medicaid expansion because they did not want to provide care to those patients. They don't have the Medicare, maternal health care benefits are abysmal. I mean, a lot, and Chicago is just one place, but it's throughout the whole country. These inequities are based in the structure. And so no matter how philanthropic you are, how giving you are as a physician, how caring you are as a physician, the structure makes it so difficult for you to be the physician that you want to be. And that's why I think it is so important that we advocate for what we see is needed out there. If we don't advocate, we know the country doesn't listen to poor people. But if we don't advocate, it will never change. And that's part of why I, work so hard with Physicians for a National Health Program. I'm the immediate past president of that organization because we know that if we deliver healthcare based on what you can pay, we will continue and worsen the inequities that we see.
Susan, I wanted to ask you about obstetrics because that service has obvious importance to community health. If you look at public health impact of medical services in general, this has the most bang for the buck in terms of improving health outcomes, infant and maternal mortality. So it turns out to be kind of expensive to have an obstetrical service for hospitals because they have to have highly trained staff at the ready all the time. You never know when the contractions are going to start and become compelling and, the delivery is going to occur. So that need to have highly trained staff available is costly. So how does this play out on the south side of Chicago and in those poor, large neighborhoods which have both poverty and major public health needs?
Yeah. A couple of years ago, there were, maybe 3 years ago or so, there were 7 hospitals on the south side of Chicago, which took care of mostly Black patients. And that decreased to 3 hospitals because the other hospitals financially could not survive. Many of those patients had their maternal health care paid through Medicaid. Others may have had insurance, but it wasn't enough to sustain the deficit that hospitals got from the low reimbursement from Medicaid. So we had maternal health care deserts on the south side. The hospital that I did my 3rd year medical school clerkship in, which was a large multi-specialty hospitals, Mercy Hospital on the south side of Chicago, had to close their maternal program because of lack of reimbursement. So what happens is those patients don't get the care they need. They don't get early prenatal care. They don't get access to care when questions come up, when problems come up. So there's a big problem with maternal morbidity and mortality in Chicago because of the lack of access to health care. And a lot of times patients may present at a hospital like University of Chicago or Rush. They still have to be seen by law if they're in labor, although that could be, changed, but whether you're in labor can sometimes be a not necessarily an objective assessment, but it leads to the leading maternal death rate in this country. And if we look at rural areas, there's over 1,000 counties in this country that do not have an obstetrician. And they are filling in with non-physicians to do maternal health care. But if you need a C-section, if you need certain procedures done, you need a physician to do that. And there are such gaps. And again, it focuses on what the priorities are of our healthcare system. It's not in providing healthcare. It's not in getting people better. It's in making money. And unfortunately, who loses out? It is poor people, minorities, rural areas that do not, it's hard to get an obstetrician to be the only obstetrician in a hospital. I mean, just practically, you can't work 24/7 forever.
Yeah.
And so it's a difficult problem to solve, but you have to be able to provide the physicians and nurse practitioners and others to provide maternal health care. And that just means we have to change the way we spend healthcare dollars. And that goes back to how we fund medical school education. It's all intertwined. it's all about the Benjamins, you know? Remember that movie? But it's about the money. And as long as healthcare remains focused on money, which it will continue to get worse as more and more private entities get involved, this is going to get worse.
All right, Susan, we should take a break now until 10:55. And we're gonna travel to Atlanta at that point. But if we have time at the end, if you could tell a story, I'd love to hear the story of Mercy Hospital. There's more to say about the more recent history of Mercy Hospital. But
Yeah.
let's let Jack take over after the break. So we'll reconvene at 10:55.
Okay.
And I went into the for-profit healthcare field, mainly to make money. Within 3 years, I tripled my income from being a state employee to being a corporate employee. That was with Humana. Then I went with Tenet as a VP of acquisitions. And then I went with some other firms that were big national healthcare firms, primarily working with not-for-profit hospital systems.
So Jack,
Yeah.
Tenet and Humana at that time both they were for-profit companies, I think publicly traded on Wall Street, that
Yeah.
ran hospitals.
Yes.
Humana has since then transitioned over to being mostly an insurance company, if I'm not mistaken, but they still own some hospitals, I believe.
When I was with Humana, I was over planning for 24 hospitals. They were transitioning to be an insurance company. It's in the mid 80s. And that's one of the reasons I decided to leave Humana. I did not want to work for a for-profit insurance company. So I left Humana and went to NME, which became Tenet as a VP of acquisitions. You know, what I can tell you about for-profit healthcare, and I'm going to go into this in a little more detail in a minute, is they can say what they want to say about wanting quality and this, that, and the other. That's just a marketing tool. The only thing they care about is the bottom line, and specifically the only thing the executives in for-profit firms care about is their bonus, their commissions, their stock options primarily. The guy I worked for at Humana was an executive vice president at the time, became president of Humana. He's president now and CEO of Community Health Systems, one of the largest hospital companies in the country. He was not worth very much when I worked for him in the 80s. Last time I looked, he's worth $450 million. So let me say that again. And this is Wayne Smith. I used to go out drinking with Wayne and carousing with him. So he was a guy that, you know, was my age. We got along well. He lived in a normal middle-class place back in the 80s. Now he's worth $450 million working for Humana and Community Healthcare Systems. So that shows you where the money's going. He's made $450 million working for for-profit hospital companies in the last 3 years.
Community Health Systems, it sounds like it would be some altruistic, publicly funded program. It's a for-profit hospital chain. Am I not correct?
Yeah, it's a for-profit hospital chain out of Nashville. Last time I looked, they owned about 100 hospitals, primarily rural. And per what Wayne Smith told me one day, you know, why would we want to serve the indigent unless somebody's paying for them? Why would we want to do that? And that's exactly the attitude that for-profit hospital systems have. And that's the reason I left for-profit hospital systems. I was making 3 times what I was making with the state, but it was pretty disgusting. So I left and went with a group called American Healthcare Systems, which sounds like a for-profit and was a for-profit, but it was owned by not-for-profit hospital systems, like many of we were talking about Philadelphia, Mainline System, which is a not-for-profit hospital system in the greater Philadelphia area, is one of the founders of American Healthcare Systems. I brought him into the group. Advocate in Chicago, which is now Advocate Aurora, I guess, or whatever they call themselves, not-for-profit system, was one of the owners. So it was a very different situation. I worked for those kind of systems for a couple of decades. So my background, and by the way, I retired 20 years ago. I mean, that's sort of strange. As soon as I made enough money to retire, I did. I moved on from San Diego to a rural setting in Georgia, which is sort of strange from an Italian Jewish guy from Brooklyn. But that's where I moved. My wife was from rural Georgia, and only child, so we moved out in the middle of the country, and I ran for county commission. And I ran for county commission to change things because people were basically being screwed. I'm a lifelong Democrat. I ran as a Republican because the Republicans came to me and said, you can get elected as a Republican, you can't get elected as a Democrat. So I formed an election committee that was virtually all Democrats. And I ran as a Republican, got elected, and got 2 terms as a rural county commissioner, probably the only chairman of a rural county commission that was an Italian Jewish guy from New York, ever. And of course, nobody knew that because everybody knew my wife, who was a Southern Belle. So everybody figured I was Baptist like everybody else in the county. So I got away with it. But in any case, I learned rural healthcare there. I learned urban healthcare working in Atlanta. And I live in a suburb of Atlanta, and I also have a place in Atlanta itself. So I'm familiar with both. My background is sort of strange. Since I retired, I'm a journalist. I've published 1,600 op-eds all over the country, mostly in the South, though, because that's where I try to zero in on. I'm also chairman of the Board of Health here in Fayette County, which is another oddity. I'm very active in the Democratic Party, and I was selected for the Board of Health, even though we have 4 county commissioners that are white Republicans. The Black Democrat is a friend of mine, and he didn't push me. I actually got elected by the white Republicans, which is very odd since I'm extremely progressive especially in healthcare and race. So I'm sort of an oddity in a lot of ways. I'm also on the board of the Georgia Public Health Association, on the board of the National Association of Local Boards of Health, and a whole bunch of other social and political organizations. I'm also on the platform committee for the state party with the Democratic Party, and I'll weave all of these into what I'm going to say now. Let me give you a little bit of background about Georgia and healthcare in Georgia. And if you ever want to get more on any of this, just Google me, Jack Barnard opinion healthcare or Jack Barnard opinion Georgia, and you'll get more than you ever wanted to know. But Georgia has the 3rd highest rate of uninsured in the country. Only Texas and Oklahoma are worse in terms of the proportion. Where I live is very different. Where I live is only 8% uninsured, which is under the national average. It's a strange little community I live in. It's about 120,000 folks. It at one time was completely white. Now it's about a 1/3 Black. And the Black folks that are moving in here, a lot of whom are my friends, are doctors and lawyers and Indian chiefs. This has become the place for Black intellectual folks to leave Atlanta and move. So this is becoming a very interesting county to be in. In any case, getting back to Georgia, Georgia's got 18% of the folks that are of working age are uninsured. So very often we talk about the total uninsured rate. What we need to zero in on are folks that are under 65. Because the folks that are under 65, it's a much higher rate. Because the old people like me, we've got Medicare, thank God. And by the way, Medicare was approved with Republican votes. It never would have been approved back in the 60s with Democrats because many of the Southern Democrats voted against it. Go back and look, you can research it. So there's no reason for the Republican Party to oppose expansion of Medicare since they were very heavily involved in getting it through Congress to start with. In any case, back to Georgia. Georgia's got the 3rd worst maternal and infant healthcare systems in the country, the 3rd worst low birth weights for children, the 3rd highest Black maternal death rates. And there are a lot of reasons for this. Susan made one of the best presentations ever about disparities in healthcare just now. So I'm not going to go try to compete with her because she's a lot better at that than I am. But I will zero in on Georgia. Georgia has had 12 hospitals closed in the last decade. Many of them were rural hospitals, which I can get to in a minute. And one was a big facility, the Atlanta Medical Center. Let me talk about the rural hospitals. As a county commission chairman, I funded the rural hospital. Frankly, a lot of rural hospitals ought to close, and a lot of progressives get very disturbed when I say that, but they need to change their focus and become outpatient centers and not be hospitals. In the hospital that I had in my county, we had 21 beds. We had an average daily census of 3. I was dumping something like $600,000 a year in county money into it. We shouldn't have been doing that. They had a nursing home that was totally full, but they only had 3 acute care beds, and the care was atrocious. So should they have a hospital open? Well, probably not. Even if we had Medicare for all, I'm not sure they should have a hospital open, but they should have some sort of decent EMS systems, which they did not have. Most of you probably are not familiar with Trisha Yearwood, the country music star, but for those of you who are familiar with Trisha Yearwood, she's married to Garth Brooks. But in any case, her father was one of my constituents. He was a great guy. He had a heart attack, and in the paper it said he was dead on arrival, blah, blah, blah. The reason he was dead on arrival is that the EMS services took 40 minutes to get to him. If you have a heart attack and it takes 40 minutes for EMS to get to you and he lived alone, yeah, of course he died. But it was because of poor health care. So that's all wrapped up in the generality of poor health care in the South, poor health care throughout the country. Let me talk about the the Atlanta Medical Center. The Atlanta Medical Center was called Georgia Baptist Hospital. It was owned by the Baptist group. Baptists are by far the largest religious group in the South. In any case, the closing of the Atlanta Medical Center was primarily a cost reimbursement issue. I wrote a column on this in 2022 for the Atlanta Journal-Constitution. You can pull it up and you can get details, but essentially, I had the Georgia Baptist was one of the shareholders in Premier, which was one of the companies that I started. That was one of the companies that was a for-profit company owned totally by not-for-profit companies. That's changed over the years. But Georgia Baptist was a shareholder. I met with the CEO, a guy named Dave Ramsey, extensively about what was going on at the what became the Atlanta Medical Center, was Georgia Baptist at the time. He told me at the time, because of their location, which was in a heavily Black low-income area of Atlanta, that they could not keep on. They were pouring money into indigent care. They had a very high Medicaid rate. And the fact was that Medicaid wasn't covering the costs in Georgia. The indigents were just being picked up and they weren't being reimbursed very well. So really, when you get down to it, that's why the hospital closed. And it was a big one for Georgia, 470 beds, which was one of the largest in metro Atlanta. And it was the second largest hospital other than Grady for providing indigent care in Atlanta. When it closed, strangely enough, Grady said, well, we're going to have to add a couple of hundred beds because it was totally full with 470 beds. So now the governor said, well, I'll give $100 million to Grady out of state funds to take care of indigents, which the whole thing made no sense. And it still continues to make no sense. But if you start looking at what happened to the Atlanta Medical Center, Tenant, which is the company I worked for as a VP of acquisitions, bought the Georgia Baptist and turned it to Atlanta Medical Center. It was an ignorant buy on their part. As a VP of acquisitions for-profit hospital system, the second largest in the country, I can tell you the only thing that they care about is profitability. And the location of the Georgia Baptist Hospital was such that they were never going to be able to turn it around. It just wasn't going to turn around, especially with racism, which is just it's a part of healthcare everywhere, not just in Atlanta. I saw racism in Chicago when I worked with the Chicago Medical Center in North Chicago. I've seen racism all over the country, but it was especially true here. They just weren't going to be able to turn that hospital around that way. They sold it to a not-for-profit group called Wellstar, which is a big not-for-profit hospital in the suburbs here. Wellstar ended up closing the hospital completely. They were the ones that sunk it. They were the ones that dumped it back into Grady. Wellstar is extremely profitable hospital systems. One of the things that was never discussed and never came out in the press, but if you look at the Form 990 for the Atlanta Medical Center, you'll find that the CEO was making $2 million a year. This is an indigent care hospital. He was making $2 million. She was making $2 million a year. The top 6 executives of that hospital together were making $7 million a year. I made a lot of money when I was in for-profit healthcare, but I wasn't making $2 million a year. So, you know, having someone working with a not-for-profit hospital system, CEO of an indigent care hospital making $2 million a year tells you what's wrong with American healthcare. That wasn't a for-profit hospital system. That was a not-for-profit hospital system. Anyway, when they closed it, the rumor has been that they wanted to make it into condos because it's very close to the expressway leading to downtown Atlanta. There's been so much hell raised by the Georgia chapter of PNHP and others that hasn't happened yet, but it will. It will. It's going to be made into condos, and they're going to be condos that are going to go for $1 million a year. And Wellstar is somehow tied into that. God only knows. I don't know how, but they are tied into it. As is true with many things, nonprofit healthcare systems are not acting altruistically in many instances. Even though I'm not Catholic, the only systems, religious systems that I saw that really were interested in the poor were the Catholic hospital systems, the big ones across the country. I worked with every one of them, including, you know, Farmington Hills out of Detroit, and I think they probably owned the Chicago Mercy system. I forget who owned them, but I worked with big Catholic hospital systems throughout the country. I worked with Jewish hospital systems, Baptist hospital systems, Presbyterian, Baptist. Really, the only religiously owned affiliated hospital systems that really cared were the Catholics. And I knew the nuns that were CEOs, and they cared about that. Matter of fact, the only thing we ever disagreed on was abortion. On everything else, they were pretty progressive. So, having said that, I'll go back to Georgia. Georgia, there are 10 states in the country that have not expanded Medicaid. The only reason they haven't expanded Medicaid is politics. In Georgia, we came up with a cockamamie idea called pathways. And Trump, when he was in office, approved it as a waiver. Biden tried to get it overturned. He wasn't able to. Court said, Trump approved it, you're stuck with it. Under the Georgia Pathways program that our governor, Governor Kemp, who will be at some point running for president, so keep that name in mind, Governor Kemp pushed this Pathways program saying it was going to cover 100,000 to 200,000 people. Pathways to date in 2 years has covered 3,000 people. not 100,000, not 200,000, 3,000 people. The cost it's technical, but the cost to the state has been the same as if they would have a normal expansion. A normal expansion would have been 450,000 people covered. So we're talking about 450,000 versus 3,000 and the same cost to the state because of federal reimbursement of Medicaid. We're getting 66%, we would be getting 90%. And when the numbers are crunched, it's equal. So why haven't we expanded it? One reason: politics. The governor does not want to be embarrassed. He wants to run against John Ossoff in 2026, and he is going to win, by the way. And then he wants to run for president. So he doesn't want to be embarrassed. What they did this session of our General Assembly is they had a deal. They were going to take away CON, Certificate of Need, and I'm not going to get into that. I started the program in Georgia back in the 70s. But if you don't understand it, it regulates hospitals. The deal was we're going to do away with Certificate of Need and we're going to expand Medicaid. Gets down to the wire, the governor tells the General Assembly leaders, I'll sign Certificate of Need because it deregulates the state. Go create a committee on Medicaid, and let's tell everybody the committee's going to examine Medicaid expansion, but don't bring me the bill. So suddenly at the last minute, it fell through. To be quite honest with you, my compatriots in the progressive healthcare community are totally naive. They think that this is a real thing, that this committee is going to come up with implementable suggestions. Having been in politics, I can guarantee you that we will not have Medicaid expansion in this country, in this particular part of the country, this state, until Governor Kemp thinks it's in his best political interests. And that's not going to be anytime soon. Public health in this state, I've been involved in public health for, I don't know, 15, 20 years. In Georgia, I've been on 2 boards of health, 4 different terms. I'm chairman of the Board of Health here, with probably the second most affluent county in the state. We don't have much power. I even got pushback from the Georgia Public Health Association when I tried to introduce a full expansion of Medicaid resolution. They didn't want me to do it. I went to the advocacy committee. They didn't want to support it. I went to the board, which I'm on. I said, am I going to get a second if I make this proposal? And you could have heard a pin drop in the room. No one wants to expand Medicaid. They're afraid of the governor. They're afraid of politics. They're all state employees, much less Medicare expansion. Where we have been successful is one of our physicians here, marvelous African-American physician, single-handedly got the Atlanta City Council to approve a Medicare for All resolution. I mean, I'd love to take credit for it, but I just happened to be sitting there. But she did it, and they approved it. Just probably out of luck, I got the Georgia Democratic Party to approve at their convention a Medicare for All resolution, Medicaid expansion and Medicare for All. Frankly, I think it's because they don't even understand the concept. I ran it through the platform committee and the nominations committee, and it got approved a couple of years ago. So officially, the state Democratic Party is on record here for full Medicaid expansion and Medicare for All. On the other hand, the platform committee that I'm on has started to walk it back, and the terminology they're using in their written platform doesn't mention Medicare for All, because I was told by members of the platform committee that Medicare for all is a dead concept and we shouldn't even be talking about that anymore. And that's the Democratic Platform Committee for Georgia.